Welcome, everyone. As president of the Association of Black Cardiologists, I am honored to welcome you to an openness webinar entitled A Labor of Love, Pulling Heart into Maternal Health, an ABC Women and Children Table Talk series. As we observe International Women's Day, which was yesterday, as you know, we celebrate the women of the ABC, including our leaders, our ABC leaders, Dr. Elizabeth Ofili, who's the chair of our board, and our CEO, Ms. Cassandra McCullough. We remain humbled by the fact that despite the importance that women play in society, Black women in particular have not equitably benefited from gender discussions that focus on the advancement of women. This is especially true related to the topic of maternal health. As you can see on this slide, in the biology of the superwoman schema, which was adapted from Dr. Cheryl Giscombe's work, a history of stereotyping and oppression, history of disappointment, mistreatment and abuse, spiritual values, as well as foremother influences, all pour into the psychological stressors that Black women face globally, especially African-American women, that result in these biological processes, including activation of sympathetic nervous system, activation of inflammation, dysregulation of the hypothalamic pituitary axis, that contribute to maternal as well as non-maternal health, resulting in adverse outcomes for Black women. Certainly, Black women are forced to be strong, to suppress emotions, show vulnerability resistance, with a determination to succeed, as well as an obligation to help others. This is all within the soil of a need for self-survival, the African-American community preservation, and the family preservation. These things come at costs. And to quote Maya Angelou, we delight in the beauty of the butterfly, but rarely admit to the changes it has gone through to achieve that beauty. And in another quote from Maya Angelou, there is a kind of strength that is almost frightening in Black women. It is as if steel rod runs right through the head down to the feet. So on this day, as I welcome you to this ABC webinar, and you know that ABC's mission is to address the heart and other needs, including stroke needs of a diverse America, and I would extend that to a diverse global community. That the Women and Children Committee that was established within ABC, led by Dr. Rachel Bond and Dr. Annette Ansong, who bring you this webinar today, and must be congratulated for their efforts in leading ABC's agenda related to maternal health and the health of Black women and their families in general. I salute my sisters in this journey and in the presentation today. Now I would like to introduce to you Dr. Elizabeth Ofili, the ABC board chair, who will guide you through the next step in the presentation.
Hello, everyone, and welcome. And thank you so much, Dr. Albert. I want to join Dr. Albert in congratulating the committee chairs, Dr. Rachel Bond and Annette Ansong, and the entire committee for the amazing work that has been done in this space. Of course, I bring you greetings on behalf of the Board of Directors of the Association of Black Cardiologists. We know that there's much work to be done, as Dr. Albert shared, but we are optimistic because there is now a lot of attention on these matters that concern the Black woman and Black maternal health, as well as children. So I congratulate you all and looking forward to an exciting video discussion and moving beyond that as well to other opportunities as we ramp this effort under the leadership of our committee chairs. Welcome, and thank you. Have a wonderful session.
Thank you, Dr. O'Feely. Welcome, everyone. Our committee, the Women and Children's Committee of the ABC, decided to create this Table Talk series in an effort to highlight the spectrum of cardiovascular disease in children, women in their reproductive years, and older adult women, along with highlighting those issues that pertain to communities of color. It is our hope that you'll find these webinars engaging, enlightening, and educational, along with empowering. We created a labor of love as our second event in the series in order to highlight the disparities and inequities that exist in Black maternal health. It is our hope that you'll be educated along with being armed with the tools to mitigate these disparities. Without further ado, I'd like to introduce you to my co-chair, Dr. Rachel Bond. She's the Systems Director at Dignity Health. She also holds a number of leadership positions in the American College of Cardiology at the state and national level. Over to you, Dr. Bond.
Thank you so much, Dr. Ansong, as well as Dr. Albert and O'Feely for those welcoming just messages of just complete support. We really do appreciate that. With further ado, I do want to also introduce my moderator for this actual Table Talk series, where we're going to walk you through a fictional case, but this case can honestly be anyone, any one of us at the end of the day, and it's really going to open up and broaden our discussions. So Dr. Phillips, Dr. Camilla Phillips, is a board-certified obstetrician and gynecologist. She's also a wife, a mother, and a lifelong women's health advocate. As an expert in women's health, she aims to demystify the body and medicine more accessible for patients. As the founder of Caleb Women's Health, her interests include health disparities, lactation, menopause, and international medicine. If we can move to the next slide, I'm going to be introducing very briefly our panelists as well, who are just esteemed guests that we're so thankful to have. First, starting off is Ms. Zara Barnes, who joined SELF in November 2015, working on the culture and health teams before eventually becoming executive editor of SELF. She has spent her career as a reporter and editor covering women's lives and a focus on wellness. Zara specializes in sexual, reproductive, and mental health, all with the goal of destigmatizing these topics and highlighting issues in underserved communities. Beyond that, she's passionate about exposing the systemic and institutional flaws that lead to health disparities for marginalized people, as well as providing services that help readers navigate the systems for the best mental and physical health outcomes possible. Next is Miss Sharon Ann Taylor Smalls. So Sharon is a certified nurse midwife who received her bachelor's and master's of science in nursing, as well as master's of science in social work from Columbia University in New York City. She is the owner and primary provider for Redeemed Creations Midwifery Services and is a member of the New York City chapter of ACNM. She is expected to complete her doctorate in nursing practice from Stony Brook University in spring of 2020. Congratulations to you on that. Next, we have Miss Denise Bolds. Denise Bolds is a Bold doula. She holds a master's degree in social work, as well as an experienced case manager for high-risk pregnancies. She's a Donna International Advanced Certified Birth Doula with over 178 births of experience since 2014. She's certified as an evidence-based childbirth instructor, and she also is a CLC providing breastfeeding support and education. Beyond that, she mentors birth doulas and is known for her advocacy and empowerment in Black birth work. Ms. Bolds is a noted public speaker, podcast producer, and host. She's a native New Yorker like myself and born in Harlem, New York, and is a successful single mom of her 30-year-old son. Moving along, we have the pleasure of having Mrs. Pamela Price. Pamela is currently the Deputy Director for the Balm in Gilead, managing the various health initiatives of the organization. Under her leadership, the organization provides support to faith institutions in areas of program design, implementation, and evaluation, which strengthens their capacity to deliver programs and services that contribute to the elimination of health disparities. In addition to her role as Deputy Director, she also serves as the Director for the National Brain Health Center for African Americans. Mrs. Price has co-developed educational curricula as well as training for the community, clinicians, nurses, and other allied health professionals, aiming at addressing knowledge and cultural competency gaps related to health inequities affecting African Americans. Next on our agenda is Dr. Tisha Gaither. Dr. Gaither is a double board certified physician in OBGYN and maternal fetal medicine. She holds a master's degree in public health as well. Beyond that, as a perinatal consultant and women's health expert, Dr. Gaither's expertise is grounded in both research and her professional experience in caring for women with a multitude of medical, surgical, and fetal conditions in pregnancy. In her current role, she serves as the Director of Perinatal Services, the Director of MFM for New York City's health hospitals at Lincoln Hospital in the Bronx. And last, but certainly not least, we are so excited to have Christy Turlington Burns. Christy Turlington Burns is the founder of Every Mother Counts and works in maternal health. And her work, particularly in maternal health, began after she experienced her own childbirth-related complications in 2003, an experience that would later inspire her to direct and produce the documentary feature film, No Woman, No Cry, about the challenges women face throughout pregnancy and childbirth around the world. Under Christy's leadership, Every Mother Counts has invested nearly $21 million in programs in Africa, Latin America, South America, as well as the United States, focusing on making pregnancy and childbirth safe for every mother everywhere. Before founding Every Mother Counts, Christy received international acclaim as a model representing the world's biggest fashion and beauty brands. And with that, that is our esteemed guest. And if we can move the slides forward, we're going to get started on this amazing journey. So we can't talk about maternal mortality without acknowledging the fact that, in particular, we know that cardiovascular disease is the leading cause overall of mortality in women. It actually accounts for over 420,000 deaths per year. With that, it is the #1 cause of maternal death. And it's easy for us to make a sweeping statement that this crisis is affecting all women, because the fact is it is. That being said, though, it's important that we highlight it's affecting different groups of women disproportionately. And if we could advance the slide forward, this actual infographic here is going to emphasize which particular group of women it's affecting most notably. We know that when it comes to Black women, they are 3 to 4 times more likely to die during pregnancy, as well as up to 1 year postpartum, compared to their Caucasian counterparts. And when we think about this moving forward, we know that the actual cause for the disparities, if you could advance the slide forward, the actual cause for the disparities are so pervasive that they permeate nearly every step of the healthcare system. The cause is not limited to one area specifically in medicine, but instead it stems from shortcomings across the care continuum. And when we talk about the care continuum, we're even focusing on preconception, meaning before you actually become pregnant. But even beyond that, the postpartum period, which is so important for us to highlight, as the vast majority of deaths and complications that we see do occur there. Advancing the slide forward, we're now going to walk you through the case. And this case we decided to call Maya, and let's meet Maya. So Maya is a 36-year-old obese Black female. She has a history of polycystic ovarian syndrome, as well as borderline diabetes. She's working on her master's in education, and she presents to her gynecologist's office for a well woman visit. She just got married 6 months ago, which she's very excited about, and she wants to start the process of getting pregnant. So what advice do we give Maya? And it's really here where we're going to open up discussion to our panelists, our esteemed panelists. And before we talk about those questions in particular, it's important for us to highlight that Black women are more likely to have a high-risk pregnancy because they're more likely to have some forms of chronic illness that begins very early on in their life. Many women like Maya have pre-existing medical conditions such as obesity, diabetes, and even hypertension, with actually obesity most prevalent among Black people, as is the case for hypertension and diabetes. In fact, 50% of Black females 20 years of age or older have some form of cardiovascular disease, with hypertension leading the cause. This is not because white people are better at taking care of themselves or are less predisposed to getting sick. We will get into the why, but let's answer the first question. What advice are we going to give Maya during this preconception counseling? And this is really a question that I'd like to first open up to Dr. Phillips as an obstetrician and a general provider for somebody that Maya would most probably first want to talk to. So please tell us what you normally factor in to preconception counseling.
Thank you for that. First of all, I would actually congratulate Maya for making the effort to make a preconception counseling visit. Preconception counseling visits are very important because it's almost like a tune-up for the patient before she decides to get pregnant. It helps us identify risk factors that could potentially become a problem when she actually gets pregnant. So for Maya, I would recommend a few things. The first is nutrition and weight loss. She has the issue of weight and a pre-diabetic status that could pose issues when she actually becomes pregnant. I would advise her to start seeing a nutritionist and continue her weight loss journey. This may not only help improve her diabetic status, but also her hypertension. I would advise her that her risk in pregnancy of gestational hypertension and gestational diabetes are real risks that we want to minimize. I would further educate her that diabetes specifically could increase her risk of a larger baby, and that could increase her risk of a C-section. So we want to try and avoid both of those. I would ask her to buy a blood pressure cuff. She could get one from her local pharmacy or Amazon. I'd also ask her to buy a scale so she could be more accountable with her weight. And from there, we would talk about seeing cardiology and maternal fetal medicine after she conceives.
Thank you, Dr. Phillips. Those are really good key factors that I think all of us should think about during this preconception counseling state. Now, Dr. Gaither, I'm going to throw the next question over to you because we know that there are times when waiting to become pregnant may be advised, and maybe Maya's case, it would be advised. As a high-risk pregnancy specialist or maternal fetal medicine physician, can you talk about when postponing pregnancy may be advised, and most notably, the value of incorporating an MFM into the care team? What are your thoughts on involving yourself even now in the preconception discussion, as well as someone like myself as a cardiologist, given Maya's risk factors?
Well, I think it's great that she indeed has come from preconceptual counseling. Certainly she has PCOS, which puts her at a great risk of developing hypertension if she doesn't already have it, as well as diabetes. So certainly she would be screened for those two things. And given the fact that she is obese, you know, obesity and hypertension are a good prerequisite for peripartum cardiomyopathy. So I would, you know, evaluate her from a cardiovascular standpoint with EKG and echo. And certainly if anything was untoward there, then forward her on to you for cardiovascular evaluation.
Completely agree. As a cardiologist, I do think that us being involved in the preconception planning is really pivotal, especially for someone like Maya who has a few high risk factors. Now, Dr. Ansong, I actually want to throw this last question over to you before we let Dr. Phillips continue with the case. And as a pediatric cardiologist and just somebody who's also board certified in pediatrics, are there some things Maya could have done as a child to reduce some of the comorbidities we're seeing now?
Absolutely. The answer is yes. Maya has the cardiovascular risk factors of obesity and diabetes, which can lead to heart disease such as stroke and heart attack. And these risk factors are very prevalent in our brown and Black children. So as pediatricians, as pediatric cardiologists, as parents, we have to be very intentional and very targeted at making sure that we mitigate these risk factors. And the way to do it is with diet and exercise. So for example, with my pediatric patients, when it comes to diet, I tell them to limit the amount of saturated fats that they eat. And the reason is saturated fats cause high cholesterol. High cholesterol is a risk factor for heart disease. So decreasing the dairy and the eggs. I also tell my pediatric patients to limit the amount of sugar. The reason is sugar brings on extra calories. Extra calories lead to obesity, which is a risk factor for heart disease. I also tell my patients to limit the amount of salt in their diet because salt drives up the blood pressure. And as we know, hypertension is a risk factor for heart disease. And essentially what I tell my parents, if food tastes too good, it's probably too bad for you. So portion control is key. As far as things that I encourage the fruits and vegetables because they are 0 calories and also are high in fiber that decrease the amount of cholesterol in the blood. And I also encourage my patients to drink lots of water as well because water is cleansing, but also gives this feeling of satiety so that patients aren't inclined to overeat and consume those extra calories that bring on weight. As far as exercise goes, I encourage my patients to exercise as a family because likely if there's a child that has a cardiovascular risk factor, there's a parent that has a cardiovascular risk factor. So exercising as a family is key. If a child sees it, then they're more inclined to be more active as well. And I also tell my patients to, cut down on the video time too, so that they'll be more active. I think the key is in promoting heart health in children is that we want to minimize or stave off the onset of chronic adult diseases so that they're not in the position of Maya where they want to start a family and they're unable to.
Thank you, Dr. Ansung. I couldn't have said it any better than what you did, because the fact is that one thing I think we really want the audience to understand and emphasize is that cardiovascular disease is preventable 80% of the time. The earlier you understand the tools of how to prevent it, the better off it will be, the better your preconception will be, because those risk factors that really do place you at a slightly higher risk won't be there. So with that, I'm going to hand it over to Dr. Phillips so we can continue our journey as we learn more about Maya's case.
So thank you. This is what Maya is told. She's given the thumbs up and told it would be best if she considered weight loss options first. Like many of us, we ask what that is. She's told that she should walk more and eat better. She asked for resources and is brushed off a little bit, told to look online. Before she can ask another question, he congratulates her, tells her to contact them once they're pregnant, and leaves the room. Like many of us, when we leave the doctor's office, Maya is a little confused. So where do we go from here? Let's look at the next. So it's important for us to understand that in many spheres, and especially in medicine, Black women have faced structural inequalities that limits their ability to access care, not only primary care, but also specialty care. And even though they're at a doctor, there's challenge with accessing the relationship in a meaningful way. So this has led to really poor identification of chronic illness and treatment of chronic illness. Let's see how we can do better. I'll turn it back over to you.
Thanks, Dr. Phillips. So before we actually delve into the question of where we go from here with Maya, it's important to highlight the fact that at the core of a lot of what we're seeing with this maternal health crisis, and yes, it is a crisis. When we think about the United States, it's the only industrialized country in the world that has the highest rates of death in the pregnancy, as well as up to 1 year postpartum. And when we think about the core, we know that structural racism does factor in. It's a significant impact on the health of Black women. Beyond that, Dr. Alberts talked a lot about the strong Black woman or superwoman phenomenon. And that is something that beyond structural racism also takes into the misogyny of just being a female. So coupling being a female with being a Black female can lead to early onset of premature chronic medical conditions, including prematurity of cardiovascular disease, higher rates of diabetes, higher rates of hypertension. So at the core of this, it's important that we factor in stress and what the actual determinants in the population may lead. Moving to the next slide, it's also important to highlight the fact that although low-income women are at the highest risk of poor outcomes, Black women across the income spectrum have the highest rates of mortality during their pregnancy and immediate postpartum period. As an example, if you're a Black graduated, a Black female who's in graduate school, such as Maya, you're at a higher risk of having either death or a complication from your pregnancy compared to a white female who may not even have a high school degree. So let's turn it over to Dr. Phillips to try to delve deeper into the why and also what Maya could do with the concerns that she's left with in the doctor's office.
Thank you. So it's really important for us to realize that structural racism and access in medicine is across the board, regardless of your socioeconomic status, education status. We've seen this with famous people such as Serena Williams, that for Black women, prestige, money, and education is not protective for us. I want to bring in Denise Bolds into the conversation. Denise, are there any suggestions that you would give at this time to Maya that might have helped her navigate her appointment with her doctor?
Yes, absolutely. Maya would definitely benefit from having a full spectrum doula support in her team building. A doula supplies advocacy, education, and emotional support to the family or the person who's preparing for birth, giving birth, or has given birth and is now going into parenthood. So for Maya, it would be so helpful to have that full spectrum doula support to really engage with her with keeping her appointments, finding community resources for her to be engaged in her health regimen, as well as to assess the environment of the home to support Maya so that she can eat more healthy and to reduce her stress and to be more engaged in her activities.
Thank you for that. So Black women are more likely to experience social determinants of health. What is a social determinant? A social determinant is everything about your life, where you live, how you travel, where you go to church, where you get your food, everything basically that impacts your health. Social determinants can determine whether you live or die in childbirth. So they're really important and a huge source of research. Furthermore, implicit bias, what is that? Implicit bias is the attitude or feeling associated with a group of people that stereotypes them, and often you don't even realize you're doing it. That's why it's called implicit bias. We have tons of research showing that this negatively impacts women of color. So between social determinants of health and implicit bias, these are both real significant triggers for certain chronic conditions like diabetes and hypertension and access to care. They can make it harder for Black women to trust and engage in a medical system, prenatal care, that has historically not been built for them. You can move forward for me? Thanks. So as discussed, race, ethnicity, and other social determinants of health are increasingly important to be aware of, and more research is noted. We know, however, that they can affect any condition in pregnancy, most specifically gestational diabetes, peripartum cardiomyopathy, increased risk of cesarean delivery, also preterm delivery. We know that low birth weight babies are directly tied to socioeconomic status, and Black women are more likely to have low birth weight babies. And they independently increase your risk for future cardiovascular disease. So moving on into Maya's story, she knows she has to do some work on her own, so she starts her research. She goes online and comes across a series of articles in Self magazine on Black maternal health. I'd like to bring in Sharon at this time. What do you think of the response of the clinician? Can you give us some insight?
I'm glad that the clinician did direct her to do some research. I would have given more specific direction to what she should look for. When I see patients, I actually spend time with them and ask them specific questions and ask them for, and give them time to really ask questions and listen to them to ask and find out what they really want to know. When I speak to them, I also give them information in writing. ACNM, the American College of Nurse Midwives, has handouts on different subjects, including nutrition, size in pregnancy, eating safely in pregnancy, information on vitamins. I would give this out to the patient. I'd also give the patient some specific websites that they could go to, or she could go to, particularly myplate.gov. When I talk about nutrition, I very frequently refer to the plate, saying that she should think of half of her plate being vegetables, a quarter of her plate being protein, and the other part being grains. That's really important. So very specific direction is really important. Patients can go on the internet and get lost. I think that's really important to give very specific directions on where to go to. If a patient is lost and confused when she leaves and really doesn't have specific direction, and if she leaves with a lot of questions, I would really encourage her to either go back to that provider and see if she can get a clearer direction from him or her, and develop a relationship with that provider where she would be heard, listened to, and be able to ask questions. If she can't get that from that provider, she needs to go to a new provider. We also need to be aware as providers of the limitations that we have based on the changes that have happened in the healthcare industry. Reimbursement changes have caused so many changes for us that the focus for us is on productivity, and sometimes we're overbooked. Patients don't know that, and that's not their problem, but we also have to use some of our creativity in giving information very quickly and developing relationships in a new way. Lastly, it's just very important to take your time and listen and share with patients.
Thank you for your advice. We find that actually Maya did do really well with finding her research online in terms of engagement with Self Magazine. Zara, can we get your opinion on some important items?
Absolutely. So I wanted to give a little bit of background into why we as a publication decided to focus on this crucial issue. And a couple of years ago, one of our editors, who is a Black and Asian woman, actually had a harrowing birth experience of her own. Luckily, everything turned out well for them, for mom and baby, but we know that, of course, so many people are not as fortunate. And at Self, we, of course, believe that personal health and public health are inextricably linked, and we wanted to shine a light on the fact that this can be viscerally personal, but this also is a huge public health crisis that unfortunately a lot of people don't even understand is happening. So I love that Maya found our resources, and our goal is to really, talk to experts such as the experts on this panel and create a resource for people who maybe don't have that provider they can trust.
Can you summarize for our participants the series and any future initiatives that Self has in this vein?
Absolutely. So one of the things I love so much about this series is it really runs the gamut. We have stories on taking care of your mental health as a Black pregnant or postpartum person. This story you see here that features insight from many different experts about how to create a birth plan for survival when you're Black and pregnant is essentially how we framed it. Postpartum care, how to advocate for yourself at the doctor. We really tried to make it a well-rounded package. And one of the things I can share that is really exciting is we have another piece in the package in the series coming out tomorrow, specifically about heart health and Black maternal mortality. And it features insight from some of you who are on this panel with me. And we plan to keep covering this issue, given that it's so crucial, for as long as it remains a pressing public health concern.
When there's so much information on the internet, how is a person supposed to identify a good resource, and how has Self established itself as a leader in this field?
That's a great question, because I know it can be so confusing, especially if you're scared or you're nervous or you're upset about something going on with your health. It can be really hard to figure out who to trust online. One of the biggest things, and something we really emphasize at Self, is going to the right sources. That's why we have spoken to some experts on this panel for some of our articles. We really want to highlight that we are getting our expertise from people who have made their life's mission to focus on these very important issues. So if you're looking at, for example, a blog post and it's saying really scary things about your health as a Black pregnant person, who are they citing? Where are they getting this information? Are they mentioning different experts? Are they mentioning organizations like Association of Black Cardiologists? Or is this information that is kind of confusingly sourced? I think looking to where people are getting their information is one of the biggest parts of this.
Thank you. We agree. It's important to have experts, and Self has absolutely identified all the experts. You guys do a great job. Thank you. So you also brought up a good transition. You mentioned when this is your life's work and you're passionate about what you do.
Gray emergency room.
I'm in the hospital.
Code gray emergency room.
Sorry
Code
about that. I'd like to bring in Christy Turlington Burns at this time, because when we talk about a woman who's taken on such an amazing topic as her life's work, if you could just start by telling us about Every Mother Counts and what led you to founding this amazing organization.
Thank you. Well, hello, everybody. I came into this world of maternal health when I became a mother. 17 and a half years ago, I gave birth to my daughter. And after an otherwise pretty uneventful pregnancy and a straightforward delivery, I had a complication in the postpartum period, and I started to hemorrhage. And I had, luckily for me, a great access to a team, a doula, a midwife, a backing physician who worked really closely as a team to manage the complication. And I felt safe, and I went home with my healthy child. And I think it was really in those, early days and weeks when I started to talk to other women about their experiences and learned that a surprising amount of people in my circle had had complications, whether with themselves or with their child. And we weren't talking about these things. We weren't sharing this information before going into the experience ourselves in the way that I think could help us better prepare and prevent some of the outcomes that some of us see. And I also thought, my goodness, I'm so lucky that I had access to these people that had the skills and the training to recognize the complication, to be able to work together to manage it. But it immediately made me think about all of the other girls and women around the world who don't have access to such teams and individuals. And so I didn't know immediately how it would manifest, but I knew that day that my experience and this awareness had changed me forever. And I committed myself to doing all that I could to learn and to become a strong advocate and to use my voice to the best of my ability, which ultimately led me to pursue an MPH at Columbia, and also to make this film, No Woman, No Cry, which even then I thought was the beginning of this journey for myself. And here we are 11 years later. I founded Every Mother Counts back in 2010 after completing the film, and really initially to raise awareness about an issue that people certainly did not know and were not talking about back in the early aughts, and to start to really amplify the stories of women, to bring some of those statistics globally and domestically to the forefront, and to help to really build momentum around an issue that was already a public health crisis, but we weren't calling it that at the time, I don't think. So, yeah.
You bring up some really important themes, and we're so glad that you had a team approach, right? That's critical in terms of getting women who are having emergencies to the right resources and keeping them safe. I wonder if you could talk a little bit about how Every Mother Counts is working to end this epidemic, especially in the United States, which is the only industrialized country that has such staggering rates of maternal mortality.
Yes, I mean, I think I first learned about the global statistics, and then when I was outside the United States, did I learn about the United States figures. And we were ranked 41st in the world back in 2003 when I became a mother, and today the WHO has said that we are ranked 55th. And so we have continued to fall further and further behind over this period of time, which is just unacceptable, given that we do spend more than any other country per capita on healthcare. Our approach is really to invest in and amplify models of care that are effective. We are promoting and advancing birth justice by taking a rights-based approach to improving health outcomes. And we're investing in community-based organizations and leaders to do this work. Our job is to support them and to, center their stories, their experiences, and do all that we can as an organization to amplify those stories. We also are working to work really closely with decision makers, thought and practice leaders, and community members on policies that improve maternal health outcomes. They increase health equity and hold U.S. systems accountable. That's a huge issue right now, is accountability and the lack thereof from our institutions. And we're really trying to help shape and introduce or advance dozens of federal, state bills and policies. And we are continuously evaluating the maternal health landscape to identify opportunities and partners with whom we can catalyze new solutions and mobilize collective efforts to close gaps in maternity care and move the needle on maternal health outcomes in the US for all. We have 17 US-based grantee partners now, spanning 12 states as of the end of 2020.
Wow, that's amazing. We applaud you for your work and are so grateful for the impact that you're having on the maternal health crisis. I want to show our next slide, which is going to show us some of our partners. You, obviously, Every Mother Counts is included.
Yes, thank you so much, Dr. Phillips. So we really wanted to acknowledge what we have been addressing, which are trustworthy resources. And with respect to that, this was actually something that the Association of Black Cardiologists had the privilege of hosting, which was a roundtable discussion focusing in on the Black maternal health crisis in June of 2020. And as you can see, we had a series of amazing organizations. In addition, now our partnership with Every Mother Counts, which is going to expand and grow. And this really leads us next to Maya's journey. If you can move to the next slide, where we now realize that Maya has grown concerned. And, she, after doing her own research, realizes, my gosh, I have a few risk factors. I'm obese, I'm of advanced maternal age, I have borderline diabetes, and I'm a Black female in America. The stress of this knowledge is bringing her to really thinking about, maybe I need to reach out to my trusted community because they always have my back. And what can I gain from them? So where does Maya go from here is really the next question for particularly one of our amazing community leaders, Pamela Price. And before I ask you that particular question, Pamela, I wanted to highlight the fact that the Association of Black Cardiologists has been a pioneer in efforts to promote cardiovascular care to churches, barbershops, as well as beauty salons. In conjunction with churches, the ABC has also worked with the Balm in Gilead on numerous occasions, really to bring the importance of faith-based organizations into the conversation. So as Maya seeks support and trust from her community, particularly the faith-based community, can you tell us a little bit about what the Balm in Gilead is and what initiatives are centered on this particular topic?
Absolutely, Rachel, and thanks so much again. This has been really already such a really great discussion, and happy to be with everyone this evening. So the Balm in Gilead for the last actually 32 years really has worked to be that bridge and that connector between the African American community, the faith community, and public health, and whatever those public health issues may be, to include the one that we're talking about here today. We really believe and understand that there's a way to harness our faith, our spirituality, our belief systems, to use it to not only change behaviors, but also to really shift societal and kind of cultural norms, and really get at some of the things that we've discussed already in terms of bias, structural racism, and issues and such as that. So we've been working directly with churches as well as other partners like ABC to be able to equip our communities with addressing these issues in a very kind of culturally competent way. And so we do that through coalition building. We do it through training or curriculum development, through toolkits, through dissemination of proven evidence-based information, and really getting it into the hands of the people like Maya, who actually need it so that we can make better informed decisions. So that's kind of like in a nutshell, our mission, our objectives, and really, again, what I get up every work today, or every day to get up and go to work and do.
Thank you so much. And beyond the faith-based community, just in general, how can trusted community leaders help with this epidemic that we're seeing when it comes to the staggering cases of death and also complications during childbirth, particularly in Black women?
I think one of the first key things that I know we strive in a call to action to our trusted community leaders and our faith leaders is to, one, get educated. I think understanding really what this issue is, what are the barriers, what are the challenges, but really being able to equip yourself with the knowledge, not what is again, what is at the heart of why Black and brown moms can't either conceive, or they conceive and the pregnancy is something that becomes a matter of life and death in a way that other communities are not facing. And so I think, one, making sure that they are educated. And then I think, two, using that platform, using and leveraging their relationships that are more trusted than other organizations or other institutions, and leveraging that in a way that they can raise awareness, that they can actually advocate for women like Maya, to really be able to get access and proper utilization to the services that we need in a way that is culturally suited to what moms need.
Yeah, I think you said two key words there: trust and advocacy. And particularly, we know that there's a historical spectrum of mistrust, particularly in the Black community. And I really do believe wholeheartedly that trusted community leaders help us, even as clinicians, in improving that relationship. Beyond that, though, using you as community leaders and partnering with you more notably is really what helps us advocate and get the message out there. So thank you so much for all you do. And I think this is a really great time for us to let Dr. Phillips continue on in our journey of Maya and see how she actually felt after reaching out to her community.
So Maya does everything that she was asked to do. She exercises more, eats better, loses weight, and to our surprise, she conceives. She's approximately 6 weeks pregnant and has to decide her next steps. She contemplates staying with her OB versus seeing a midwife and possibly the addition of a doula. Let's figure out where she should go from here by bringing in Sharon, our midwife. Sharon, you with me?
I am here.
So, very straightforward question for you. What role does the midwife play in the care of patients?
The role of the midwife is to really offer accessible, high quality healthcare that promotes healing and health. And it's wholehearted quality care, which would include, for a woman who has risk factors, would include collaboration with an MFM or a cardiologist or an MD if needed.
So that answers my second question then. Midwives do collaborate with obstetricians and high-risk doctors.
Absolutely.
Awesome.
Usually, their second meeting is with, in my practice, their second meeting is usually with an MFM. When they go for their sonogram, they usually meet with the MFM for their second meeting.
And our MFM on the panel is Dr. Gaither. Dr. Gaither, what does Maya need to be thinking about in her first, second, and even third trimester now that she's pregnant?
Well, at 6 weeks of pregnancy, all of the systems of the fetus have already been developed. Now, given the fact that she may be diabetic, this is really important because diabetes can confer a lot of congenital abnormalities to the developing embryo, specifically of the baby's brain and spinal cord, the baby's heart, and the baby's limbs. If she comes to be within the hypertensive range, given the fact that she has PCOS and she's obese, then we have to concern ourselves with fetal growth. So there are a number of things that we have to be concerned with, not only for the baby, but for her as well. Diabetes can impact her eyes, her kidneys, her heart, and hypertension the same.
Yeah, thank you. So we know that as obstetricians and as maternal fetal medicine specialists, we are not only looking after the baby, but also the mother, and those needs change throughout the pregnancy. So that's important for her to know. Denise, let's bring you in. And I think it's important at this time to talk really about the history and the role a doula plays for someone who's on their pregnancy journey. Can you give us a brief explanation?
Sure. Doulas go way back. I mean, they go back into ancient times, where in Greece, in the Greek home, when the woman was getting ready to have a baby, they would call a doula in to help in the home and help the woman give birth. So the term doula is a Greek term that goes way, way back, and it is used for slave, for a lack of a better translation of the word. But fast forward to today, doulas really do a lot of things in the community. We're frontline workers for those who are expecting and parenting, as well as be the link in the community for resources and communication, as well as advocacy. And we also promote education. So for Maya now, she realizes that she's pregnant and she's on this amazing journey in her pregnancy. Having a doula come in now to support her would really help to keep her resources linked with her in the community, to actually help her to understand the importance of learning how to advocate for herself at her doctor's visits, and how to set up her advocacy team when it comes to the birth of her baby, through the use of a birth plan. I also call them birth preferences, to strategize, her breastfeeding, to talk about her support systems, as well as to keep her team connected on her goals with her and her husband, as well as to talk about the postpartum plan, because that's where a lot of Black women actually come into challenges. They do a lot of preparation work when it comes to the actual birth, but they kind of neglect the postpartum side of things. And as we saw in the earlier slides tonight, the superwoman paradigm is very prevalent here. So having a postpartum plan is just as important as having a birth plan.
Yeah.
And for Maya, the doula would be working very closely with her and her family in making sure that they can achieve very realistic goals in the birth of their baby, and also changing the birth narrative for that lineage of family, because in generations, Black families did not always have the most positive stories to tell. So doulas could actually do something to change the narrative, as well as to bring about customer satisfaction with their prenatal care providing.
Yeah. So our next slide actually hints to that. If we can move forward, it's important that people really consider their birthing team. We know that midwife care has been impactful in low-risk pregnancies to reduce the number of necessary interventions and fill in gaps of care for patients who need greater connection to social services. And we know doulas are an integral part of a birthing team because they show positive outcomes, especially for women of color, and can help navigate a system, especially when it comes to women who need healthcare advocates. So moving forward.
So we're going to continue now with Maya. So, you know, despite the fact that she had some reservations with her obstetrician due to the fact that they weren't always able to hear her and listen to her most notably and provide her that resource that she was asking for, she decided to give them a shot, and she remains singularly in their care, especially as after asking, she finds out they don't routinely work with doulas. Maya asks if there's anything further she can do to reduce her risk of poor outcomes, and she's told, keep up the good work. Despite doing this, at 22 weeks gestation, she's unfortunately diagnosed with gestational hypertension. Where does Maya go from here? Moving to the next slide.
So gestational hypertension is a really important concept for people to understand. This is elevated blood pressure during pregnancy, and it can be diagnosed only as early as 20 weeks and beyond. Next slide. It's important that we understand gestational hypertension really because it's a continuum, and that continuum can also include preeclampsia or the more severe disease, eclampsia. These are both tremendous risk to both the mother and the baby. So it's important that you know about them. Moving on. Go ahead.
Yeah, so when we think about hypertensive disorders of pregnancy, they're actually a lot more common than we think, in that 1 in 10 pregnant women unfortunately experience it. And why cardiology's involvement is so pivotal is because the fact is it can increase your risk of heart failure, a heart attack, as well as stroke, really within the next 1, 3, or even 5 years. So it's in the very near future, not even the far future. And we'll highlight the importance of getting cardiology involved as we move along with Maya's case. Moving forward.
I think the other way. So even with the stress of her new diagnosis, her first pregnancy, Maya's overwhelmed. She is encouraged though, because she's only on 1 blood pressure medicine. And we make this point because it is possible to require more than 1 blood pressure medicine to adequately control your blood pressure. At 35 weeks, however, she develops a headache, and there's always important trigger signs that you need to be aware of. And this is one of them, because now she's diagnosed with preeclampsia. What do we do now? It's important to note, I think I might have gotten off. It's important to note that communication and other access is a key step to improving Black maternal health, and acknowledging a Black woman's concerns is pivotal as part of her routine health care. Next.
And when we think of Maya's case, you know, being she's diagnosed with preeclampsia, she does get admitted to the hospital and is on the labor and delivery unit. Her blood pressure and standard blood work are checked very regularly, and despite all efforts to maintain the blood pressure with medications, her preeclampsia now progresses to severe preeclampsia. And unfortunately, an urgent cesarean section is performed. What do we do now?
I'm moving forward. So 1 in 8 maternal deaths can occur between 42 and 36 weeks postpartum. This is so important because especially during COVID, women are being sent home much earlier than before. And some of these conditions can develop after. And with limited contact with your midwife or doctor, we're seeing worse outcomes. Dr. Gaither, let's bring you in here. Can you talk to us a little bit about preeclampsia with severe features and what that means?
So preeclampsia is a spectrum. It goes along a spectrum from mild to severe. Mild involves blood pressure elevation of 140/90 or greater, and minimal protein being spilled in the urine, and maybe some edema of the arms and the legs. Severe preeclampsia, however, involves a lot more. It involves blood pressure of 160/110 or greater, significant protein being spilled in the urine, seizures, brain herniation, something that's known as cortical blindness, where the edema of the brain is such that the optics don't work. And yes, you physically can see, but because of the brain swelling, your optic nerves are not working, so you cannot see. You can have liver rupture, pulmonary edema. The baby can be impacted with severe growth restriction. The placenta can come off. The blood can become abnormal in the sense that you're unable to clot, and the kidneys can fail. So severe preeclampsia is really life-threatening. And once a diagnosis of severe preeclampsia is made, the treatment is delivery of the baby. The other thing that can happen is the peripartum cardiomyopathy. Preeclampsia is damaging to multiple bodily systems, particularly the heart, not only during the intrapartum period, but during the postpartum period, and certainly, as was stated, years afterward. So it's really a bit much.
Really important. And just to bring Dr. Bond in really importantly here, should cardiology be involved in her care at this point?
Yeah, so as I think I alluded to earlier, I really feel very strongly we as cardiologists should have been involved even in the preconception period, knowing that Maya had a series of risk factors that could have led to this. It would have possibly allowed us to collaborate with the obstetrician, discuss the benefits of getting a maternal fetal medicine provider involved early on as well, and even talking about the possibility and utility of something like a baby aspirin, which we know modestly can reduce one's risk of preeclampsia. That being said, it's pivotal that cardiology gets involved now. And I do strongly encourage the physicians and clinicians out there to consider getting cardiology in the inpatient setting. Why? Because it allows for an easier transition of care when they are sent home. That transition of care would require an appointment with somebody like myself as a cardiologist, where we would be following them along in the immediate postpartum period, but most notably at least once a year thereafter, to really make sure that those traditional risk factors like blood pressure, cholesterol, diabetes, their weight, if they're exercising or eating healthy, all of the things Dr. Ansong focused on earlier on in our discussions are optimal and ideal. So without a question, Maya needs cardiology, and I really do feel very strongly at this moment in time, someone like myself needs to be consulted.
Yeah, thank you for your input. So at this point, we're going to move to the next slide, which is her outcome. Maya's delivered. She's delivered prematurely, and this is 35-5, which we do consider premature. She's monitored very closely, and her blood pressure appears to be stable. She's discharged to home with medications and routine follow-up. However, some of the instructions are unclear. Right now, we want to talk about what her postpartum care plan should be and how she should navigate the next 6 weeks of postpartum. All right. So one thing that is often a concern is fragmented care. Do you want to talk about that, Dr. Bond?
Absolutely. And when we think about fragmented care, as I alluded to, getting those pivotal consultations in the hospital, that will hopefully prevent this fragmentation. But beyond that, we know that fragmented care can leave a woman experiencing gaps in care, as well as consequently poor outcomes. We also know that in order to assure that the system of care is transferable, there has to be a consistency to it. Beyond that, we also know that there needs to be support, that women can access the support from one central place. And I think this opens up the discussion for me now to pivot the question to you, Dr. Phillips. What is an ideal time for Maya, who has just delivered, is now working through her really ideal birth plan? What would be an ideal time for you to follow up with her as an obstetrician?
So I think it's critical that patients, first of all, are not discharged to home until they are stable and their postpartum plan is well established, and often that includes visiting nursing services, which does take some time often to be established. So once visiting nursing services established, I would discharge Maya to home with follow-up as soon as the next 24 to 48 hours for blood pressure monitoring. She can be monitoring her blood pressure at home, but I would want a professional in her home to do that as well. I would see her at the end of the week in the office and give her very strict precautions about when to return to the hospital. Furthermore, this is a time when a doula could come in and help support her, making sure she's taking her medicines, assist with breastfeeding, but minimally, she should be seen within the week of discharge.
Exactly. I couldn't agree more. Really within that 5 to 7 day window, given the severity of what she experienced. Now, we know that sometimes that's not feasible. And honestly, even beyond 6 weeks, we know that's not feasible, especially as some insurances don't provide ongoing postpartum care. And this question is actually directed to you, Christy. How can we ensure appropriate and equitable postpartum follow-up? And what are organizations like yours, Every Mother Counts, doing to advocate for the extension of postpartum coverage?
Thank you. I mean, I keep, as I hear this story, the more that I want a doula for Maya at every stage of her experience. Well, one of the many bills that have been introduced as part of the Momnibus really has been working towards this extension of Medicaid coverage well beyond what is typically provided. The hope is to get it extended to a full year, which would encompass some of those postpartum mortality rates that we've seen. And so we've been really working very closely with policymakers on that particular set of bills. As well, for this particular case and for Maya, I feel like organizations like ours and others can really help to curate some of the information and the resources that are there so that it isn't this overwhelming set of information, and to help guide and navigate as Self Magazine is doing. We created some guidelines around the COVID pandemic this past year, and have been updating those throughout the period of time, just to make sure that information is as current and as accurate as possible. That's something that I think organizations like ours and others can continue to do to sort of fill the gaps.
Yeah, and that's a really great transition into a question specifically also for even Pamela as well as Zara. Beyond organizations, what do you think, particularly for the postpartum period, community leaders as well as trusted media sources can do, and what resources can they provide to someone like Maya who may want to really seek her own knowledge depending on when she gets home? And Zara, if you can begin maybe with your thoughts on that.
Sure. Well, I think one of the most important things is something we're already covering, which is raising awareness of the fact that it's very important to stay on top of your postpartum care as much as possible, which I know is easier said than done. But one of the stories we did outlined the very specific symptoms people should know that should alert them to the fact that they might need care. I think that is very important, and community leaders expressing that it is important to stay on top of that is key. Another thing that we've found is really great is community leaders helping to connect postpartum parents with other postpartum parents who might understand what they're going through. Those types of kind of experiential connections can often become the people who really hold you up when you're struggling.
I think that's a wonderful idea. And that's really, I think, what are your thoughts, Pamela, on that, even from the faith-based community and providing that sort of, community feel and making sure that we're providing that support for Maya even now in her postpartum journey?
And absolutely, I couldn't agree more, I think, with both Zara and to what Christy both said, because I think it is about how the community plays a role in the advocacy, both in policy, but I also think when we just think about Maya or women like Maya, how do we create the wraparounds that they need once they leave the hospital? So once they've exited the healthcare system, even if it is for a time being, what can our faith leaders do? And I think, Zara hit it It's the connecting, I think, to other mothers who, you know, because there's power in just sharing of our stories, and what we all experience is a very powerful thing, and lessons are learned out of that. But I also think, just in addition to partnering and pairing maybe other or connecting other moms, I think it's also our churches play a really critical role in connecting to those supportive services that Maya may need. So she may have issues with actually paying for her medication. So can the church, again, serve as an information hub, so she may know if there's some prescription assistance places that she can go through? Are there Pampers, diapers? A lot of our health ministries work to actually provide those things that moms need when we go home, to include respite. You know, whether a mom may be dealing with things such as postpartum depression or just bringing a new baby home, that in and of itself is a stressful thing. And so our faith leaders can play a role in providing both that kind of counsel and support, but also allowing their churches and their facilities to really serve as these centers or support places for new moms, or expecting moms. You know, I really think just women in general is what we're trying to move our faith leaders into this space of being able to use their spaces beyond Sunday morning and Wednesday evening Bible study.
Absolutely. Thank you all so much for that. And honestly, Maya in particular really needs to have a better understanding of even what future pregnancies may look like. And I think that organizations, as well as trusted media sources, as well as the faith-based community, can be one way of helping her even in her future pregnancy. Moving to the next slide, if you may, this is really where we wanted to end on. We wanted to end on a very high note, which was collaboration and the benefit and success in collaboration. So the situation that someone like Maya had experienced, it does not have to exist. As you heard today, there are tools, and that collaboration is not necessarily making sure that you have a trusted physician, but it's also thinking about doing your own resources and education, thinking about moving along with, you know, trusted media outlooks, as well as the faith-based community or other community leaders that you trust, or organizations, many of which we listed. Beyond that, we want to make sure that our patients feel well informed. We want to make sure that they have good outcomes and that they don't face some of the negative outcomes or challenges that many of them may face solely because of the fact they don't have that support and those social determinants that we address. So here are just the list of a series of collaborations between cardiology, OBGYN, maternal fetal medicine, doulas, midwives, nurses, absolutely. Beyond that, organizations such as, you know, the Association of Black Cardiologists, Bold Doula, Redeem Creations, the Balm in Gilead, Self Magazine, and Every Mother Counts, most notably. And with that, I'm going to hand it over to Dr. Ansong to close things off before we open it up for questions. And if you do have any questions, please feel free to place it in the chat box for us.
Thank you, Rachel. So tonight we've been discussing the fictional character of Maya, but Maya is all of us. Let's now honor those real-life women who experience pregnancy-related complications and/or maternal death. We'll say her name. Reagan Robinson, 29-year-old, who died of cardiac arrest after giving birth. Dr. Shalone Irving, 36-year-old, died weeks after giving birth from complications of high blood pressure. Kira Dixon Johnson, 39-year-old, died after a routine C-section that resulted in internal bleeding and cardiac arrest. Amber Rose Isaac, 26-year-old, died after an emergency C-section and bleeding after a complication of preeclampsia. Next slide. Those were 4 of the many Black women who passed. Hopefully our webinar and campaigns such as #HearHer have given you the tools to embrace your maternal health. Let's now proceed to our question and answer section.
And here we really just want to open it up to the panel. We have a few questions and we really want to have open discussion right now in the final few minutes of this amazing webinar. And I really hope that those listening in really had the opportunity to understand the importance of the maternal care continuum, again, from preconception all the way to postpartum. But one particular question is that we know that part of the collaborative efforts also must include the partner as well as family members in Maya's life. How can you, or how can they particularly support people to be a part of the journey and help advocate for their partners? So for example, Maya's husband, how could he have been impactful? And I think for this, I'd love, Denise, for you to maybe take this question as a doula in particular and figuring out how to get the family involvement a little bit more.
Oh yes, absolutely. It's the partner is the most important person on the team because the partner knows the birth giver, the mom who's expecting. They have a good rapport of trust and understanding. And how do we get the fathers engaged? Well, we have sessions for fathers. I support a group called Fellas Facing Fatherhood, where men actually have a peer-to-peer conversation. Experienced dads with new incoming dads. Let's talk it out. Let's have a session just with the doula and the dad. Mom is not even present, so that the dad can basically communicate his concerns and his comfort levels going into this pregnancy and birth and facing fatherhood. I think communication is very important. And I think that societal assumptions have really blocked the father and shut the father down, whereas doulas really work to elevate and keep the father's presence in the birth team, which he's very, very important and very necessary to be there.
Yeah, and we've seen a few examples even in more higher celebrity cases, such as Serena Williams with her husband, Alexis Ohanian, as an example. And beyond that, even in Kara Johnson's case, her husband has been an extreme advocate during that unfortunate situation, and most notably after the situation as well. Now, to the same point in medicine, and I think I'm going to pivot this question to Dr. Ansong, if I may. In medicine, we continue to deal with implicit bias and acknowledge that male clinicians may minimize complaints of female patients. In acknowledging this, we want to make sure that there is good insight on ways to advocate for yourself as a patient, but most notably, how can we as clinicians hold our colleagues accountable? We have, at least on social media, this campaign called #HeForShe, but how can we uphold our colleagues, particularly our male colleagues who may not necessarily feel as comfortable and or may have their own implicit biases when dealing with these particular patients?
Yeah, I mean, I think we have to be comfortable about talking about these issues openly and honestly, and we have to make our colleagues feel comfortable about discussing these issues openly and honestly. I mean, issues of race aren't, it's not an easy subject, and some may not feel as readily comfortable to talk about them. So we have to open ourselves up so that others can come and discuss these issues as well. And also, call out our colleagues if they say or have actions that are, detrimental to a patient's care, whether it's from implicit bias or other factors, but in a way that doesn't sort of turn them off from accepting your recommendations, and in a way that they'll learn from. So I think that's key, sort of creating that environment where folks feel comfortable exchanging information, and also at the same time not condoning actions that could be detrimental to a patient's care.
Absolutely. And we also know one way of really helping this is to diversifying the field, specifically the medical field. And I know that Dr. Albert is still on, and I wanted to know if you can have the opportunity just to kind of express what ABC is doing to increase the pipeline, particularly as we know this will probably help with the outcomes that we're seeing.
Absolutely. Thank you, Dr. Bond. So certainly one of the major initiatives that the ABC has embarked on is focusing on the throughput and the pipeline of underrepresented minorities in medicine, particularly Blacks. We were involved in several efforts, including webinar efforts. We recently had a roundtable where we are working on various strategies that came out of that roundtable, implementing them, focused on increasing the pre-medical students into the pipeline to get them into medical school and into careers in STEM. We're also focused on thriving once you're in medicine, because we know that many drop off of the ladder in medicine even after they've gotten their medical degrees. And then also we're focused on collaborations with other organizations in order to improve leadership opportunities for Blacks in cardiology and Blacks in medicine in general. So we're involved in a lot of different things. Our FIT committee, Fellows and Training Committee, and our membership committees are putting on various journal clubs and webinars focused on either pipeline, career development, and other activities. So please join us for all of those things. And this was a wonderful webinar, by the way. It was fantastic. Thanks.
Thank you so much, Dr. Albert. And I do want to bring Maya back into the discussion, because one thing we didn't talk about was that she was actually worried about her chances of conceiving. And that is a real worry for women, with higher rates, specifically Black women, of infertility. Even, when we think about women of color, we know that there may be a taboo around that. Why do they particularly have higher rates? A lot of it has to do with the fact that they have higher rates of fibroids. Now, what I want to have the opportunity to do is, Dr. Phillips and/or Dr. Gaither, can you delve in a little bit into this taboo of fertility in the Black and Brown community, and hopefully mitigate any misconceptions of fertility options that we have out there?
I'll start. I see women of color every day, and although it is something that's important in the Black and Brown community, really all women struggle with fertility. And so I think part of the important part is to normalize challenges with getting pregnant and for infertility. A primary cause in the African American community certainly is fibroids. And this is one instance where I think we see the systemic racism in medicine play out, because if 90% of white women were affected by fibroids and this impacted their ability to conceive, work, live healthy lives, they would have the research and the advances in this issue that unfortunately we do not have. And so when 1 in 8 women in the United States are dealing with infertility, this is a huge issue. It's important for us to talk about our concerns with physicians and with our fellow women, so that we can have support around this issue. And when we open our mouths and start talking about fertility, I share my fertility struggle with my patients all the time to help normalize it. They see that it's not taboo, that it doesn't have to be this dark stain that we hide from. And when you open your mouth and engage in the conversation, you learn about all the resources and options that you do have, and that helps move us forward in this conversation.
Thank you so much. And I do want to give the opportunity to see if Zara, Christy, Pamela, Sharon, Denise, and/or Dr. Gaither had any closing remarks very briefly that they wanted to share with us before I hand it over to Dr. Ansong.
Well, I think that any woman who is desiring pregnancy should have a preconceptual consultation with their provider, because that can uncover a lot of hidden issues that may be important moving forward once they get pregnant, not only for them, but for their developing baby. Certainly if you're diabetic and hypertensive, that is a primary goal for you to take care of. And also initiate prenatal vitamins with folic acid during that first 3 to 6 months preconception. Those are my pearls.
Thank you. And Pamela?
I think the nugget, if I could give for folks who joined us today to take away, is that it really does take a village. And as simple as that really sounds, like we have our squads for shopping, we have our squads when something new is out, a new movie, a new show. We had watch parties for Coming to America this past weekend. I think we also need to invest that same energy, that same time into finding who our village is going to be again, earlier in our reproductive journey that begins much earlier than what many of us begin talking about it. So I think, yes, having the conversations that we aren't having and realizing that it really does take a village, and let's find our village and the people who will be in our village earlier rather than later.
Thank you for that. And Zara?
Yes, thank you. So the main thing I would love to leave viewers with is that you know your health best, and all of the experts we talk to for stories, whether it's about heart health or another concern, emphasize how important self-advocacy really is in these situations. That is another thing that can, of course, be so much easier said than done, but there are resources out there that can help you learn to advocate for yourself, or find a health professional who will listen to you advocating for yourself if your current one will not.
Beautifully said. And Christy?
Yeah, I'll only just add that it's been such a pleasure to be with all of you, and I've learned so much. And I think having opportunities where you can have so many perspectives and expertise all in one place, like this is so powerful for so many women. And I just want this information to be shared with more people so that we can get women to the place where they can advocate for themselves and know which questions to ask for themselves, and tell their sisters and their friends and their circles like what they've learned, and just keep passing those words on and that information forward so we can all be healthy before pregnancy, during pregnancy, and postpartum.
Yeah, these discussions are really going to help decrease these staggering rates that we're seeing. Denise, do you have any closing words for us?
Yes, I do. Thank you so much for this wonderful opportunity. As a certified birth doula and a Black woman, I cannot emphasize the importance of having a doula as part of the team. There are doulas that fit every budget and every culture, whether you're a Christian doula, whether you are more evidence-based, whatever your budget is, please make the effort to secure a doula. Black women do so well when they have a doula as part of their care team. I had the honor last week of working with Dr. Phillips, and we had a wonderful experience. Black women deserve doulas. It is not a best kept secret. It is not just for the wealthy. It is not just for white women. Black women deserve doula care and support, and it really is a wonderful way to change the birth narrative and stay connected with the community. I'm really proud to be a Black doula, and I'm especially proud to serve my Black and brown families.
We are proud to have you here today. So thank you again from all of us at the ABC. Sharon, do you have anything else to add?
Most important thing, it's really important to develop a relationship with your healthcare provider and have a healthcare provider that will listen to you and spend time with you. That's the most important thing. Once you have a person who will listen to you and spend time with you, they'll get your history and they'll be able to cover you. And when something comes up, feel free to ask questions and trust them. So that's really important. Have a relationship and be listened to and have someone to spend time with you.
Absolutely. And honestly, for myself as a clinician, I can say that the collaboration, particularly as a cardiologist, with the obstetricians, the midwives, the doulas, as well as even the MFMs or the high-risk OBs, is such an impactful and pivotal part of really helping to reduce these risks. And that's really what we wanted to highlight. Getting these specialists involved earlier on may help to reduce these outcomes as well. As Dr. Ansong very nicely said, giving the patients the tools earlier on is really the core of this. So with that, Dr. Ansong, can you please close us off? And thank you all again for just joining in. It was wonderful.
Thank you, Rachel. So we want to thank our panelists and our audience for joining us this evening for what was an amazing presentation. I would encourage you all to check out the ABC at our website, abcardio.org, and to consider membership. And membership is open to all. You don't have to be a cardiologist. You don't have to be in healthcare. You don't even have to be Black to join the ABC. So we'd love to have you, so please join. And if you want to see further programming from the ABC, like what we're doing tonight, don't hesitate to donate as well. And lastly, if you could look out for our next Table Talk series, we plan on covering issues with older women and cardiovascular disease. Look out for that in mid-spring. Thank you all again and have a good evening.
Bye-bye.
Thank you. Bye-bye.
Bye, thank you.
Thank you, guys.